بسم الله الرحمن الرحيم. أهلا بكم أبنائي وبناتي طلبة ال Competence Based Medical Bachelor Program of Tanta University في Neuroscience 2 Module Questions and Answer Lecture. معكم بروفيسور أشرف أبوالصفا Professor of Neurology Tanta University. We have to review some topics of the Neuroscience 2 module in question and answer. Question number 1. We have today 4 questions and their answers. We'll discuss them. The first: a 40-year-old man was admitted to the neurology service for evaluation of persistent numbness over his left jaw and lower face. MRI reveals a schwannoma, which is compressing a cranial nerve as the nerve exits the skull. The cranial nerve involved in this case exits the skull through which of the following foramina? A. Foramen ovale, B. Foramen rotundum, C. Foramen spinosum, D. Jugular foramen, E. Superior orbital fissure. The answer is A. The foramina of the trigeminal nerve divisions can be remembered with the mnemonic standing room only, SRO, for the superior orbital fissure, foramen rotundum, and foramen ovale, which transmit cranial nerves V1, V2, V3, respectively. This patient has a schwannoma of the mandibular division of the trigeminal nerve V3, third division, as the nerve exits the skull through the foramen ovale. Compression of the third division of the trigeminal nerve causes numbness over the ipsilateral jaw and lower face. Answer B is incorrect. The maxillary division of the trigeminal nerve, the second division, exits the skull through the foramen rotundum, and the compression would cause decreased sensation over the cheek and middle face. Answer C is incorrect. No cranial nerves exit through the foramen spinosum. The middle meningeal artery exits through this opening. Answer D is incorrect. The jugular foramen transmits the glossopharyngeal, vagus, and the spinal accessory nerve. Answer E is incorrect. Cranial nerve 3, 4, 6, and the first division of the fifth exit the skull through the superior orbital fissure. Lesions of these nerves would lead to ipsilateral extraocular muscle paralysis and numbness of the ipsilateral forehead and upper face. Question number 2. A 63-year-old homeless woman is brought to the ER by the police, who noted her to be disoriented and confused. On questioning, the patient appears to be having a problem with her short-term memory, frequently forgetting what questions she had been asked. She provides plausible details of the events prior to her coming to the hospital, but the police report to be untrue. On physical examination, she is emaciated and has nystagmus and unsteady gait. Examination of the emergency department records reveals that she has presented multiple times in the past for alcohol withdrawal. The lesion accounting for the patient's symptoms is located in which part of the brain? Basal ganglia, Broca's area, cerebellar vermis, maxillary bodies, or vernix area? Answer is D. The patient presents with classic signs of Wernicke-Korsakoff encephalopathy, which is associated with thiamine deficiency and chronic alcohol abusers. The classic signs are confusion, disorientation, anterograde amnesia, confabulation, oculomotor dysfunction, and motor ataxia. The lesion is located in the mammillary bodies. It's an easy. Answer B is incorrect. The maxillary division of the trigeminal nerve, the second division, exits the skull through the foramen rotundum, and the compression would cause decreased sensation over the cheek and middle face. Answer C is incorrect. No cranial nerves exit through the foramen spinosum. The middle meningeal artery exits through this opening. Answer D is incorrect. The jugular foramen transmits the glossopharyngeal, vagus, and the spinal accessory nerve. Answer E. Third question. The third question is, a 30-year-old man comes to the physician because of headaches that occur at night and without warning. They begin in his left eye and then generalize to the left side of his face. Alcohol can precipitate the attacks, which last for less than 1 hour. The patient rates the pain as a 10 over 10, and multiple over-the-counter analgesics have resulted in minimal benefit. He's given a prescription for sumatriptan to treat his symptoms and is prescribed verapamil for prophylaxis. Which of the following is the most likely diagnosis? Cluster headache, medication overuse headache, migraine headache, temporomandibular joint dysfunction syndrome, or tension headache? The answer is A. Cluster headache. The patient has cluster headaches, which are repetitive headaches that occur for weeks to months at a time, with intervening periods of remission. Men are affected more than women, with a peak incidence 25 to 50 years old. Attacks begin without any prodromal symptoms, typically around the eye or temple, and are excruciating in quality. They are always unilateral and may last for minutes to hours, with a mean duration of 45 minutes. In contrast to patients with migraine, who favor remaining in a dark, quiet room, cluster headache patients typically prefer to stay active. Treatment is difficult because of the short duration symptoms, but effective options include oxygen, intranasal lidocaine, and triptans. Prophylaxis may consist of treatment with prednisone, verapamil, or methotrexate for 1 to 2 months. Answer B is incorrect. Why? Medication overuse headaches are secondary to excessive use of analgesia and may occur in patients who have tension, migraine, or cluster headaches. The diagnosis should be considered in patients who have frequent or daily headaches, despite the use of medications. Although this patient is taking over-the-counter medications, the periodicity of the headaches precludes the regular administration of analgesia, which would be necessary for the consideration of this diagnosis. Answer C is incorrect. Why? Migraine headaches can be preceded by prodromal symptoms, and they can also be bilateral in nature. Typically, the headaches increase in the severity and they can last from 10 to 12 hours. They may be associated with nausea and vomiting. Frequently, such patients have family history of migraine. Effective treatment involves the use of triptan. Answer D is incorrect also. Why? A headache induced by temporomandibular joint dysfunction is a result of masticatory system dysfunction and frequently presents with the unilateral ear or auricular pain radiating to the jaw. The pain is deep and continuous, is most severe in the morning, and can be associated with jaw dysfunction. Treatment is aimed at the underlying joint malfunction. Answer E is incorrect. Tension headaches. Tension headaches are the most common headache syndrome, but typically present with pain that's bifrontal and squeezing. They may be accompanied by nausea, but not by vomiting or photophobia, and are not preceded by prodromal symptoms. Acetaminophen and nonsteroidal anti-inflammatory drugs are typically effective for relief of such pain. The last question, number 4. 24-year-old man with a history of intractable seizures has recently been switched to a new anti-seizure medication by his neurologist. He subsequently develops a rash on his body, which consists of maculopapular blistering lesions with central erythema surrounded by a halo of erythema. His neurologist also notes that he has developed lesions on his gums and anus. The neurologist discontinues the medication immediately and admits the patient to the hospital. Laboratory test results show sodium 130 milliequivalent per liter, potassium 4.2 milliequivalent per liter, chloride 101 milliequivalent per liter, carbon dioxide 25 milliequivalent per liter, blood urea nitrogen 10 milligram per deciliter, creatinine 0.3 milligram per deciliter, white blood cell count 700 per cubic millimeter, platelet count 250,000 per cubic millimeter, hematocrit 39%. Here's the white blood cell count is grossly diminished. Which of the following medications most likely to have resulted in the patient's symptoms? Carbamazepine, gabapentin, phenytoin, or valproic acid? The answer is A, carbamazepine. This patient is experiencing Stevens-Johnson syndrome, a hypersensitivity reaction with symptoms that include erythema multiforme with mucocutaneous lesions and blisters, systemic symptoms, fever, malaise, headache, and epidermal detachment. The condition is serious. It's a medical emergency and has an associated mortality rate of approximately 5%. When this syndrome is related to pharmacologic etiology, the offending agent must be discontinued immediately. Patients are treated like burn victims and often require aggressive fluid replacement, pain control, and antibiotic therapy. Although many anticonvulsants, particularly phenytoin, are associated with Stevens-Johnson syndrome, hyponatremia and agranulocytosis are rare adverse effects characteristically associated with carbamazepine. Answer B is incorrect. Gabapentin is commonly associated with adverse effects, including sedation and ataxia. Answer C is incorrect. Phenytoin, commonly associated with adverse effects, including gingival hyperplasia and hirsutism. Answer D is incorrect. Valproic acid is commonly associated with adverse effects, including tremors, gastrointestinal symptoms, nausea and vomiting, weight loss, hair loss, hepatotoxicity, and rarely thrombocytopenia. Thank you.